Good morning, ladies and gentlemen. Welcome to this Health and Wellbeing Board meeting today, Thursday, 9th of October 2025. And just a general warning that this is being videotaped and also audio taped, so beware of what you show to the cameras. And let's move on to the first item. The first item is that we have made some small changes, two changes, but significant changes to the terms of reference. We have added one, to receive regular reports. Am I going too fast? Yeah. Yeah, I will finish this and then do that. To receive regular reports from the board's working groups, including the Healthy Weight Alliance, Tobacco Partnership, PNA, and authorize, where appropriate, delegate authority to these groups. And in the second section, the last but one basically explains what are all the organizations we would be discussing. So I hope that is acceptable to the board, these two changes. So with that, I will now formally enter the meeting. First, you can start recording if you haven't. So let us just introduce ourselves, starting from me. I'm Chair Paul Egil-Shelvan, Councillor for Cramlington South East.
Good morning, Graham Size. I'm a GP in Alnwick. I'm a clinical lead with the ICB for North East North Cumbria, and a local clinical lead for Northumberland and North Tyneside.
Morning everyone, Jill O'Neill, Executive Director Public Health.
Good morning everybody, I'm the Cabinet Member for Adult Services and Health.
Morning everyone, I'm Vicky McLeod, I'm the Director for Children, Young People and Families here in Northumberland County Council.
Good morning, Rachel Mitchison. I'm Director of Delivery for Northumberland and North Tyneside for the ICB.
Good morning everybody, Audrey Kingham, Executive Director for Children, Young People and Education in the Statutory DCS.
Morning, Abby Conway, Chief Exec of Citizens Advice, representing Thriving Together.
Hi, Neil Bradley. I'm the Executive Director for Adult Services here at the Council.
Morning, I'm John Casely. I'm the Chief Inspector for Communities for Northumberland Area Command, Northumbria Police.
Hi, Hugh McKendrick, Health Watch, Northumberland Chair.
Hello, Sharon Williams, Community Pharmacy North of Tyne.
Morning everyone, Ashley Eyston, Head of Public Health Nursing and Operations here in Northumberland and Gateshead.
Good morning, Rob Clough from Northumberland Fire and Rescue Service, representing the Chief Fire Officer.
I'm Sandra Green, I'm the Community Alcohol Detox Coordinator for Northumberland Recovery Partnership.
I'm Sarah Hulse, I'm the Alcohol Strategic Manager from North East North Cumbria ICB.
Hi, I'm Sue Taylor, I'm Head of Alcohol Policy for Fresh and Balance.
Morning everyone, I'm John Liddell, I'm the Drug and Alcohol Lead within the Public Health team for the Council.
Andrea Todd, Democratic Services.
Thank you all, and we have our council leader, Glenn Sanderson. We just introduced ourselves, Glenn, so I introduced you. Okay. Sorry. Let's move to apologies for absence. Right, so we have apologies, Councillor Carl Green, Lindsay McVeigh, but there is a substitute attending, Robin Clough. Rob Murphy has sent his apologies, and Kevin Waring, but you are attending, John. Thank you. Now, shall we agree the minutes of 11th September 2025 as a true record? Yes, thank you very much. Now, disclosure of members' interest. I think we have one item today, which is about how to tackle alcohol abuse. So if you have any members' interest on that issue, please let me know. There is none. Let's record that as a none. So now we will look at the one and only item, alcohol strategy, in a very comprehensive way, from multiple directions, and this will be introduced by our cabinet member for adult services, Health, Councillor Eve Chicken.
Thank you, Chair. Good to see everybody here today. I'm really happy to introduce this alcohol strategy to Council and ask your approval to have it released. There has been a lot of work that has gone into this alcohol strategy. We've sat in previous meetings where we've talked about how much work's going into this strategy and how much work's going into that strategy. But as you can see for yourself, there is an enormous amount of work that goes into these strategies and just how good they are. They're not done quickly. They're done over a number of years. They operate and they survive within a very challenging set of circumstances. We work with the community, we work with our partners, and we develop strategies that are there to help the public and its health. This particular strategy focuses on alcohol with 4 main aims. One is prevention of alcoholism and those health issues that are surrounded by alcoholism. Recognition of alcoholism, those signs that people may not know are signs. We also look at having a safe space for people to recover in and live their lives whilst they are dealing with alcoholism. And finally, the actual treatment of alcoholism, working with our partners. There's very few people within society who have not been touched by somebody, has seen somebody, has witnessed something about alcoholism. However, it can be hidden. It's not always the person that you think it is. It's not the bum on the street that is sat there with his bottle of plonk in a brown paper bag. That's really not the top and bottom of it. Unfortunately, alcoholism can hit anybody at any age because it's so available to us. It's easy enough to say you stay away from drugs, you stay away from things that harm you, but alcohol is everywhere. We all access it. We access it from quite an early age, in all honesty. But recognising those signs, is it somebody who has become stressed at work? Is it somebody who's dealing with other mental health issues? Does alcoholism cause mental health issues? It certainly causes physical health issues, which we all know about. The main organ that is affected by alcohol is the liver. Now, sometimes people believe that because the liver is the only organ in the body that can actually repair itself, that, oh, it's okay, it's not a killer anymore. It is. Alcoholism is a killer. But it's not just the person who is the alcoholic that is affected, it's the whole family. It's their environment, it's their communities. Unfortunately, some people are driven to strange behaviours. They're driven to stealing, they're driven to a whole world of behaviours that are not their norm. It's not their normal character because the alcohol has taken over. This strategy works to deal with all of that, particularly with the prevention. If we can prevent something, it's far better than curing it, but unfortunately we can't prevent everything, so we must focus on how we cure things, how we deal with them in society, because people don't get taken out of their day and put into some sort of alternative universe. They have to deal with it. They have to deal with it in the workplace, they have to deal with it in the home. Their children, their family, they're all part of it. So this strategy deals with all of those elements that's in there. Like I say, there's been an awful lot of work that has gone into this. It hasn't been a short strategy. It's really comprehensive, but actually very, very well written and very easily to understand. There's been multiple people who have been involved in this. So now I'm going to hand over to our guests for today, who are going to talk you through the finer detail in a very precise way. Thank you.
The first presenter will be John. He'll be making the introduction. We would like some discussions after each presentation, and there are also paper copies of the presentation, so if you are quite comfortable with the paper copies in addition to seeing it on the screen, please come and help yourself. John, can you please move on with that one?
Thanks, Chair. And thanks for having us along today. It's really appreciated. So ordinarily, for a piece of work like this, perhaps I would come along and just give you an update about the strategy itself with a little bit of context, a little bit of background. But because we've been given a little bit longer today on the agenda, I'm really pleased to say I've got some colleagues along with me today. Some of the, a small part of the people who helped me put this put this strategy together, and have been really, really instrumental in developing it, and will be part of the, the delivery program we have as well in place. So I'm really pleased to have them along with us today. Thanks, Councillor Chicken, for that introduction. Absolutely fantastic. And you've touched on a lot of really interesting points there. I'm hoping over the course of the next kind of 40 minutes that we kind of come back to a lot of those and offer a little bit more context to some of them and potentially some solutions as well. So, what we're going to do is, over the course of the next, as I say, the next sort of 45 minutes or so, is we're going to give you a little bit of an overview about, I suppose, why we felt we needed a strategy in the first place. Why did we need to take the time to sit down and put something on paper? We want to talk about who we talked to and what they told us. I want to touch on a little bit about what the assets we already have within Northumberland, and again, my colleagues are going to sort of a representation of that. We want to talk about also ultimately what we want to achieve. So we will cover a lot of the harms associated with alcohol. We'll go into a bit more detail about that. We do want to talk about what the key issues are for Northumberland, how some of the issues are quite distinct to us, who our partners are, and of course, you know, how we can prevent and reduce harm. So I've got with me today, we've got, as well as myself, I've got Sue, Sarah, Sandra, and also Amy with me today to help me out. So just as a little bit of opening kind of context from me is, alcohol is you know, as you all know, has a very, very central kind of role within society, within our communities, within our lives. It's very, very visible. It's very, very present. It's not something you can easily ignore if you try to do so, or if you choose to do so. You know, go into any supermarket, there'll certainly be one aisle dedicated to alcohol. It could be 2 or 3, to be honest. If it's around about Christmas or perhaps a big sporting event, alcohol will be everywhere. It'll be near the checkouts. It'll be at the end of aisles. It will literally be right in your face. Alcohol is available from all kinds of outlets. Some of them we may find a little bit unusual, but it's in there. I always use that post office example because there's a post office near where I live that sells alcohol. It's in there's probably about another 3 places you could buy alcohol from in a 50 square stamp, basically around that 50 square area around there. But you can get alcohol. You can go to the post office and buy a bottle of vodka if you choose to do so. Guinness sponsorship is very prevalent. Guinness sponsors, of course, Six Nations, men and the women. Sports with alcohol sponsorship is very prevalent. You won't see alcohol sponsorship on Premier League football shirts anymore. That's because the FA made a decision to not allow that. That is partly based on the idea of protecting children, so not having kids buying football shirts that have got alcohol sponsorship on there. So that's quite a positive decision, and it's an example of where large organisations do recognise the harms associated with alcohol. Alcohol advertising is again very prevalent. A lot of rules associated with alcohol advertising, some of which I think are perhaps bent slightly by the alcohol industry. You're not supposed to portray alcohol as life-enhancing, but watch any advert for, I've used an example there of one of the kind of Italian lagers. It tends to be beautiful people, very well dressed, on sun-kissed terraces, having a fantastic time. It does feel a little bit life-enhancing. Star Trek beer, who knew? Who knew we needed that? I spotted that in a shop near where I live just yesterday, so I had to go online and see if I could get a screenshot of it. Exploring the universe, one brew at a time. I don't know what the genuine connection between alcohol and Star Trek is, to be honest, but someone's decided there is one, and they've marketed that. So this is how, I mean, it is quite funny, I suppose, but this is how alcohol creeps into all aspects of society. All of our cultural references are for grabs, basically. And the one at the end there, drink-free days, is, of course, there is now a lot of alcohol-free products. So on face value, a good thing, but these are still branded with the alcohol organisation that made it. So you still get their branding, perhaps being pushed into spaces that previously were alcohol-free. And in this case, this is Heineken talking about drink-free days, which of course is part of something that we all should considering. But this is saying if you have a drink-free day, make sure you still consume a alcohol industry product. Alcohol harms. Eve talked about alcohol harms at the beginning there, and this is very relevant. And as Eve Councillor Chicken said, you know, we might associate alcohol harms, especially the kind of sharp end of it, with you know, perhaps a quite extreme example of someone being homeless, someone, you know, having this absolutely devastating impact on that individual, and that does happen. Although alcohol can appear after homelessness, to be honest, it's not necessarily the cause of the breakdown. It can make an appearance later on, so it can be at both ends of that. But alcohol has an influence, obviously, on other areas. Blue light services will tell you just how much of a feature it is in their day-to-day delivery of their jobs. People end up in hospital very, very ill in some cases. The bottom right picture, is simply an inability to get up and function. You might not regard yourself as an alcoholic, but if you're missing days of work or you can't get your kids ready for school because you're drinking too much, that is having a serious impact on you and the people around you, and also the local economy. Centre picture will be perhaps a familiar sight, town centres. This is often an issue where this may not actually even be taking place, but people might perceive it takes place, and it keeps people away from certain areas. It might make people avoid going into town centres at night, because this is what they imagine will be happening, even if it isn't. They might think it is happening. There's a very strong perception amongst people about the harms that alcohol takes within our city centres. The bottom left one, I could have picked anything, but I also cover gambling, so I've picked a more straightforward one for me at least. Risky behaviour. People have a few drinks, they take risks, their inhibitions go out the window, and you know, we've all read kind of sort of funny stories really about someone going on eBay late at night after a bottle of wine, and a yacht turns up on their doorstep next day because they've put in a bid that's been accepted. But the reality is, inhibitions do kind of get forgotten about. Sometimes people take risks. Gambling, online gambling, lots of online gambling takes place late at night. Why is that? That's because people have had a drink. People can lose thousands, people can lose their livelihoods over this. Their lives can be absolutely destroyed. Just some of the background. I'll not talk too much around graphs because it can be sometimes a little bit difficult to interpret, but just some of the drivers behind developing an alcohol strategy for Northumberland is we do have a few issues where people are coming to quite significant harm. Alcohol related hospital admissions, so this is the narrow definition. This is where alcohol is absolutely the cause of someone ending up in hospital. And although we're the top line, and although ours are going down, which is really pleasing, we're still above the England average. We want to be below that average. We want to drive that down as low as we possibly can. This is people who, in some cases, are seriously ill because of the alcohol they're consuming and ending up in our hospitals. Deaths as a direct consequence of alcohol. So this is where alcohol has killed somebody. Where the line at the top again, you'll see ours are generally coming down, which again is really, really pleasing. But we did have this spike around 2024. Most areas in the northeast had that spike, to be honest. It's at least partly linked to the pandemic, where people's alcohol use kind of spiraled in some cases and harms went unchecked, unfortunately. Thankfully, ours are coming down. Ours are going in the right direction, but we're still above the England average. All northeast local authorities are, to be honest, but we're driving that down, and we want part of the things we're talking about today, the work that we want to deliver. It could be said that the ultimate task is to stop this kind of thing happening. You might see how clear this. You might struggle with that a little bit. It's not as clear as it perhaps could be, but just to touch on the fact that the map on the left is our areas and neighbourhoods that suffer the most in terms of deprivation are judged to have the highest levels of deprivation. Mine's gone off, as everyone's gone off. So I've committed to memory. The one on the right is where we see alcohol related hospital admissions, and there is a correlation there. There is a similarity. Areas where we see high levels of deprivation, we will also see high levels of hospital admissions. We'll see high levels of alcohol deaths as well. Right, I'm going to pause there. That's just the intro, and that's some of the reasoning why we felt an alcohol strategy was relevant. I'm going to start passing over to my colleagues now who can give you a lot more kind of context. So as I say, each of them are going to take about 10 minutes. We'll stop for questions after each one as well, because they'll be talking about quite a specific area, and it might prompt a question that is best asked kind of now rather than waiting until the end. Okay, Sue, can I hand over to you, please? This one.
Just the.
Oh, sorry.
Thank you. Thanks very much. So as I said earlier on, my name's Sue Taylor. I work for an organisation called Balance, which hopefully many of you will have heard of. And we are commissioned by public health teams within Northumberland, Tyne and Wear and County Durham to try and take an evidence approach and work with yourselves in partnership around alcohol harm reduction. John's really articulated some of the harms. I think they're linked to alcohol incredibly well, and I think having that kind of visual representation, particularly of things like the advertising, really helps to bring home actually how alcohol can stretch across society. But I think the thing that I just wanted to start off with is that alcohol harms touch every part of our lives. So I think, you know, the alcohol industry in particular likes to portray alcohol as being a very positive thing, and albeit we do appreciate alcohol can play an important part in the context of the nighttime economy, I think the harms do stretch across society. So, for example, here you can see some of the medical harms. There's a link to around 200 medical conditions, including at least 7 types of cancer. I think, interestingly, alcohol is really a risk factor for younger people. So you see there the ill health, the disability is driven very much amongst younger people within the population. And the average age from alcohol-related death is 54. So it is taking people who are living at the prime of their lives and think of the knock-on impacts in terms of communities, families, the workplace, and so on. And, you know, as John said, alcohol deaths are at record levels with the highest rates in the North East. I think Northumberland is slightly below the North East average, but still higher than the England average. And I think, again, it kind of represents the scale of the challenge. From a perspective of crime, it's a massive driver of things like antisocial behaviour. We're seeing around 4.2 million alcohol-related crimes. This is an England and Wales figure, costing nearly £15 billion every year. And the link with violent crime, I think, is particularly strong. So alcohol plays a huge role in things like sexual violence, in domestic abuse, in the violence that we see in nighttime economy as well. So just thinking how that stretches and the impact that that has on the police. And then also we know that alcohol has a big impact on children. So many young people within the region are carers for adults who are suffering from alcohol misuse. And, you know, the link there with things like neglect, truancy from school, and knock-on impacts that has for young people for the rest of their lives. And John very much touched on this, but I just wanted to really kind of reflect on where are we now as a society when it comes to alcohol. And I think, you know, often when we look back on the past, I think we can get some kind of indication on where we are now. So comparative to, you know, 1987, for example, we see that alcohol is too affordable. So even with increasing prices within supermarkets, things like, you know, everyday staples, the price of alcohol has remained relatively stable. So it is relatively much more affordable than it was. And this is relating very much to the off-trade. So we found that alcohol was available for as little as 13 pence per unit in the North East. That was a few years ago. But actually, I don't think it has increased too much since then. So you can still get things like cheap white ciders very cheaply in off-trade. Alcohol is also too available, and I'll mention later on that the government has just launched a consultation on the future of the licensing laws, which we'll be responding to, and which we're really concerned actually about some of the proposals, which I'll talk about later in my presentation. But already here in the North East and nationally, we do have a really high outlet density, and, you know, premises are particularly concentrated in more deprived communities. So, you know, the likes of South East Northumberland that John was pointing out, the highest health harms and things like that, actually the outlet density within those communities is really high, and actually the licensing laws are already very permissive. And, you know, John mentioned post offices, but also petrol stations, soft play areas. You know, actually the licensing laws do very little to protect that kind of widespread availability. We also think alcohol is too heavily promoted. I won't go into that, as John's mentioned. And I think key here is the alcohol industry has access to the heart of government. So the licensing reform, the call for evidence, which was launched today, the licensing task force was comprised and co-chaired by an alcohol industry representative. The Department of Health was excluded from that original task force, even though health is clearly a really important consideration within the licensing process, and public health is a responsible authority at a local level for licensing. And I think that just gives you a real flavour of the access that the industry has to the heart of government. And I think, where do we want to get to? And I think this is important, you know, Balance as an organisation, I know partners in Northumberland, this is not about being anti-alcohol, but this is about having alcohol having an appropriate place within society. So, you know, evidence would suggest that if alcohol is less affordable, if it's less available, if it's recognised as harmful, and if it is less desirable, then those are all key drivers in terms of reducing alcohol harms, reducing consumption at a population level. At a national level, we're really closely working with partners across, and I know that this is reflected as well within Northumberland, with partners across tobacco, obesity, gambling. And I think, you know, having that kind of focus across unhealthy commodities really helps to give more weight to the arguments around alcohol. I think for us, and again, partners locally, we want that harm reduced amongst the most vulnerable groups. There has been a downward trend actually in consumption amongst young people, which we want to continue in the future. Big alcohol industry excluded from policy making, and, you know, I mentioned before the kind of impact that alcohol industry is having at that national level. And I think, you know, overall alcohol playing that more balanced role within society. And I can't emphasise enough, and again, you know, in the light of the licensing reform, the call for evidence, this isn't about targeting pubs. You know, this isn't about undermining the industry and the on-trade, but actually what it is about trying to really target the cheapest, strongest alcohol, which is predominantly sold within the off-trade. So you can see a couple of statistics there. You know, UK off licenses have increased. We all see convenience stores, you know, the likes of the post office, selling alcohol. We're seeing that within our communities, often taking over actually from buildings which used to be licensed as pubs. Back in 1974, there was around 90% of beer was sold in the off-trade, in the on-trade rather. By 2014, this had flipped on its head. So for the first time, alcohol sales from the off-trade actually exceeded those on-trade sales. And following the pandemic, increasingly people are choosing to drink at home. You know, it's probably due to on-trade prices being higher than off-trade, but around 80% of all alcohol consumed is now consumed within the home. Within the North East, public opinion, I think, is with us on this as well in terms of regulating hours of sale. So 95% of North East residents feel that there are enough or too many places selling alcohol, and 55% of respondents, and actually that was far greater than people who disagreed with that, felt that off-trade sales should be limited between 10 a.m. and 10 p.m. And also we've seen an expansion in online delivery. So again, thinking the challenges that these present our communities. And as I said before, you know, cheap off-trade alcohol really is driving those harms. So I won't work through all of the statistics here, but I think you can see the comparison between the average price of a kind of pub pint of lager at £4.70 compared to one in the off-trade, which is around £1.51. And that's probably a more expensive example. You know, thinking about the multi-buy deals that are available in the off-trade as well, the price per unit is clearly much lower. So there are a number of things that we would be very much calling for with yourselves around regulation of price, particularly of off-trade alcohol. So possible opportunities around that, things like the reinstatement of the duty escalator. The Chancellor will be doing the autumn budget shortly. Things like minimum unit price. We've seen from Scotland that actually this can have a huge impact when it comes to reducing population harms. It has reduced hospital admissions, it's reduced deaths. So now actually the rate of deaths in the North East is now actually higher than the rate in Scotland, and that follows the implementation of MUP in Scotland, and things like bans on multi-buy. So there are a number of things that we can do around price. I just wanted to briefly touch on the impact of alcohol when it comes to the actual cost to society within Northumberland. So we work with national and local partners to commission these cost profiles, and it gives you an indication of the cost that this is having for Northumberland. So for the local authority and the partners working within that, the cost to Northumberland is around 146 million each year. So that equates to a cost of 454 per capita of the population. And again, clearly, in times of huge austerity, we're seeing an impact in terms of crime disorder, health, the economy and social care, which cannot be sustained. And these are alcohol harms, and albeit, again, alcohol will bring some positive effects in terms of, you know, on-trade and growth. However, the costs clearly do outweigh those. And moving on to what can we do to reduce alcohol harms? There is actually a really strong evidence base. I think sometimes we kind of forget that there is that evidence base. And I think a lot of that, you know, you're seeing through the local strategy which has been developed, really fantastic strategy that's been brought together through lots of partnership working, and the prioritisation of alcohol within the local system, I think, is absolutely fundamental. So, you know, don't underestimate, I think, what can be done. In terms of the actual evidence base, when it comes to things like World Health Organization and Public Health England evidence review, there are interventions that we know. So in addition to the fantastic local work that is happening, At a national level, we do need more action. So this is why we're working with yourselves to call on government to regulate things like the price, the availability and the marketing, because, you know, clearly local policy isn't implemented within a vacuum. And I think the challenges that John was outlining at the start around the advertising, around the pricing and the availability, I think all of those need to be regulated nationally to allow you to do your jobs locally. Other effective interventions around things like raising awareness through mass media campaigns, prevention and treatment of alcohol use, which I'm sure Sarah will talk around, and things like labelling and drink driving laws, both of which the government is looking to regulate on, and which is good news. And just in the light of that, we've worked very much with partners, and this is a document that we've produced for partners in the North East. We did it in consultation with yourselves, calling on national government to act. So it was kindly endorsed by Jill and her Director of Public Health colleagues, police and crime commissioners within the region, the Integrated Care Board, which Sarah represents, the North East Mayor, amongst others. So this is a document which really sets out the scale of harms within the North East and really sets out some practical asks from government when it comes to reducing those harms at a national level. And as I said before, you know, the fantastic work that's happening locally needs to be done in a more positive environment to really kind of push forward with change. And again, just to reassure people, there is a strong public mandate for all of this. I know, you know, a number of elected members in the meeting today, but I think people in Northumberland do support a lot of the work that we are calling for. So, you know, John mentioned before that kind of perception of disorder and things like the nighttime economy. Over 80% of people in Northumberland do perceive that alcohol is a big problem and a big societal problem. You know, 45% feel that the government isn't doing enough to tackle alcohol harms, compared to 5% that feel that it's doing too much. 48% support things like minimum unit price, compared to 22% that oppose. And I won't go through all of these stats, but actually it gives us a really strong mandate, I think, in terms of pushing forward with change. Just coming towards the end of my presentation, I wanted to run through just a few key advocacy opportunities. You know, minimum unit price, I've talked already about the evidence from Scotland, and alcohol duty I've mentioned. I just wanted to unpick a little bit more. I mentioned the Licensing Task Force Call for Evidence, which has been launched by the government this morning. If any of you listening to the radio this morning, you'll have heard really kind of pro-industry rhetoric. This is the one where I mentioned that the chair of Green King, the industry body, was instrumental in drawing up these recommendations. There are a number of recommendations which the government is calling for evidence on, which I believe are really concerning, I think, for local democracy. There are suggestions that they want to introduce some kind of national licensing framework, which would potentially take away powers from local communities within that licensing process. There are a number of things around removing so-called outdated conditions from licenses, again, which could remove things like alcohol multi-buys. And I think there are, as I say, a number of things within that call for evidence that are extremely concerning when it comes to the potential for increasing alcohol harms and increasing the burden on frontline services within Northumberland, and particularly in taking away that local decision-making power. So we'll be working very closely with yourselves to make sure that we get a strong North East and local response to that, and try and challenge some of the more difficult recommendations within that. Just other things in terms of advocacy around things like promotion. We will be calling for action to control advertising. This is something, again, within the gift, potentially the local authority to kind of look at local advertising spaces. There's a labelling consultation which is due shortly, which again we'll work with you to respond to. And then I know within Northumberland you do amplify balance campaigns and other campaigns from the ICB to really try and get those messages around alcohol harm. And so to summarise that, I know that's been a bit of a kind of whistle-stop tour through a few different issues, but I think through the delivery of the local strategy and the system working and the kind of partners who are represented today, I think there's an excellent opportunity to really focus on that delivery of alcohol harm reduction. And, you know, I'm so pleased to see the strategy in Northumberland. I think you've got an excellent strategy, I think, which will give you an excellent start going forward. And I think, you know, the clear evidence base I mentioned before around those opportunities for national change in particular, hopefully will give you better conditions to try and deliver the local strategy as well. I would say, again, it's not about restricting economic growth and regeneration, but this is very much around targeting the cheapest, strongest off-trade alcohol. And this is what's really driving harm in communities. The 80% that are drinking at home, largely buying from off-trade, getting alcohol at very cheap prices relative to other commodities. And this is the alcohol that we really need to try and hone in on to protect some of the most vulnerable groups from harm. And I think hopefully together, you know, implementing this strategy, we can support that longer term growth, economic prosperity and the development of safer, stronger, healthier and more diverse communities, you know, communities that aren't just based on the alcohol offer that the government was outlining before this morning, but something that really gives communities in Northumberland that opportunity to thrive in the future. So those are my slides, and very happy to take any questions.
Thank you very much.
Thank you.
Thank you very much. Are there questions for Sue? It's an excellent presentation. I mean, it was a kind of a whistle-top to telling everything and with the emphasis. Yeah. Are there questions for Sue? Yes.
Thank you, that was very interesting. Actually, one of the things that you mentioned, I was going to mention, and it just clearly went out of my head. I spend quite a bit of time in Spain, and when you go into a convenience store or a shop of any sort, even though they're open till sometimes 12 o'clock at night, the alcohol aisle's closed off by 10 o'clock. You cannot buy alcohol after 10 o'clock. And you don't tend to find there's as many people drinking in the streets, although people will sit and drink at a bar, a restaurant, and they'll sit and drink in a relaxed atmosphere. You don't tend to find that you see people spilling over on the streets and being able to actually consume more alcohol within the convenience stores, which I think is quite an interesting strategy to look at. One of the things that alarms me is the two ends of the spectrum, where you've got your younger generation who are binge drinking, they're at university, wherever it may be, and we concentrate heavily on saying, you know, don't binge drink, it can be very dangerous for you. There's all sorts of health issues associated with that, but we don't talk about alcoholism within the younger generation, because you tend to find that, because we get these statistics of people that are that little bit older that have problems, and it's come around after a number of years. We don't talk about alcoholism in young people. I actually went to school with a young lad who died at the age of 21 from alcoholism. And that was a major shock to me, because it meant he'd been drinking for a good number of years to get to that point. So I don't think we talk enough about alcoholism in young people. We talk about binge drinking, but not alcoholism. And the same with the other end of the spectrum, where we have people who don't think they have a problem, but they're sinking a bottle and a half of wine every night. But because it's wine, it's not a bottle of whiskey, it's not, you know, umpteen cans of Stella. They don't think that's an issue, but then it sort of arises. For example, if they have an accident, they break their ankle, they go in hospital, and all of a sudden the hospital has to ask them how often they drink, how much they're drinking. They don't realise that's actually a problem. And that's not talked about enough. My question to you is, where are you getting your statistics from? When you said 80% of people think alcohol is a problem, where are you getting those statistics from? Because I'm always interested in this. I work in the health and fitness industry and in politics, and I've never once been asked to fill in a survey or to ask any of these questions about the politics, you know, these surveys that come up on the board, or about health. And I would like to know where you're getting your information from, where we can expand that. Thank you.
So from the statistics, I can't speak, the statistic around 80% is from Balanced Public Perception Surveys. So each year we carry out a survey which looks at behaviours linked to alcohol. So it asks people around their own consumption. And it also asks about a number of societal issues and support for various advocacy measures. So that's annual data that we have stretching back to 2009, and that will give you a Northumberland sample as well. So it's done randomly within the population, but it is representative of that population. And there was part of the strategy consultation, there was local consultation, which John and the team led within Northumberland, asking about a variety of alcohol issues. But I think as well, you know, we use a lot of national data sources. There's some fantastic data through the NHS site, so things like fingertips, that really we kind of feed into all of the work that we do and try and underpin, you know, that kind of needs assessment of the population.
Yes. Abby.
Really, really interesting report, and I think we can all appreciate the kind of wider impact of alcohol harms. I was really struck when you talked about the sort of, I don't know your term, on and off and all, but like pubs and things like that. And I think to Councillor Chicken's remark, the cost of alcohol consumption in pubs is astronomical compared to the cost of buying it in the supermarkets. And whilst I absolutely support that minimum unit price for alcohol and can see that, you know, if it's working in Scotland, why aren't we doing it? a lot of what you talked about really just ignored the pub industry. And actually, even if we bring that minimum unit price down in supermarkets, that doesn't change that behavioural switch that we've now seen. Because when you are drinking at home, there is no limit. There's nobody telling you that's enough now. You know, we've put all that pressure on pubs and clubs, haven't we? Is there other work going on there around kind of, you know, because to answer your point, in Spain, the cost of drinking in cafes and bars isn't the same as it is here. Hence why people are doing it more, as well as the sunshine and the general niceness. Yes.
I think for me the biggest challenge is that price differential. So, you know, if you go into a supermarket, if you go into an off-licence, then you will find alcohol at incredibly cheap prices. And I think minimum unit price would specifically target that off-trade, the off-licence alcohol and the supermarket alcohol and bring the price up so it would close the differential. With pubs and clubs, I think, you know, the issue in the UK over a number of years, clearly the pub trade, I think it is struggling and prices have probably gone up as a result. I think, interestingly, some of the proposals today are outlined very much from government that they are going to be a big boost to the on-trade. But I think we've seen that actually demand for those kind of services is declining. And I think in our response, we'll be looking at diversification of that kind of nighttime economy, the way that different people can be catered for. And the offer doesn't have to solely revolve around alcohol. So I think that's quite an important distinction. But I think particularly ensuring that the off-trade and the supermarket, the cheapest alcohol, is impacted by minimum unit price. And that kind of price gap is probably the biggest driver in terms of getting people back out into some kind of entertainment economy and using the services and the pubs that we know help to support local growth, I guess.
Thank you. Yeah, Neil.
Yeah, I mean, likewise, an excellent and really stimulating presentation. I'm just struck as I sit here thinking about the issue with, and I guess we all know a number of people that have struggled with alcohol, either in family, friend groups and things like that over the years. And in terms of the list of things that you're trying to achieve here around price increases, restrictions on advertising, etc., it's all about that closing down and making it more difficult for people. I just think back to many of the people that had alcohol problems. I'm not sure that would have worked. I think they'd have found a way, and I suspect they're the group that are the most heavy drain on the NHS, the most heavy drain on the police as well, in terms of how that manifests itself in terms of behaviour. I mean, we look at drugs, we look at cigarettes, you know, I mean, cigarettes is the classic, isn't it? They're miles ahead in the agenda of open prices. I mean, we even have pictures of chewers on cigarette packets, etc. It hasn't stopped people smoking. At the nub end of those with the hardest addictions, they still smoke. And I just wonder if there's a slightly more positive approach for us to try and get to around, I mean, people drink for a reason. It can be escapism, it can be stress release, it can be social interaction, etc., and probably a number of other things. Do we need to find some alternatives to sub people in? I mean, I used to like a glass of wine after work, after a stressful day. I've subbed exercise in there for it. I accept that isn't an alternative for everybody. Some people don't want to do exercise, but it's about trying to find something to replace. Because I think if we just concentrate on banning, reducing and making it difficult, people always find a way. Even in prohibition in America, they still found a way in terms of getting the alcohol. It's maybe a bit of a combo of two things. Now, I know we've heard one part of it here, and this is not me saying I don't think we should do that. We absolutely should. I just wonder if there's something else as well, if we really want to hit the hardest to reach people.
Yeah, absolutely. I think it's a really good point actually to raise at this stage. And I think it's interesting. The evidence that we have from Scotland shows that minimum unit price and other interventions, they work at a population level. So, you know, they're not necessarily targeting that kind of real hard end. And I think this is where the treatment side of the agenda comes in. For those people who are suffering from the worst kind of addictions and, you know, who will get hold of alcohol, whatever the case. I know Sarah will talk about that. I think it's interesting. We work with a number of people with lived experience, so we're always feeding those kind of views in. So there's a lady that we work with from Northumberland who talks really compellingly about the impact that things like alcohol advertising had on her. So she talks about, you know, she saw a pink gin advert, for example, on the telly. I think she'd been in recovery for a couple of years. She saw that advert and she immediately relapsed just because the kind of power and that lure of, you know, the kind of promise of it all. And, you know, I think for me, having a society in which you kind of have those population interventions, clearly there are some people that they won't reach. However, I think if you shift that kind of societal attitude towards alcohol, then I think it probably helps to kind of alleviate those problems for a lot of the population. So that's the principle that we're working on, the kind of evidence base, but I certainly take your point.
Yeah, that's a very good point, actually. Yeah, I mean, in the sense, sometimes people do, no matter what we do, so we need to, you know, provide them some kind of an alternative. Yeah, yeah. I mean, you want to come back?
I think just to add to Neil's point, this is the alcohol support support for people with alcohol and issues tends to be quite standalone, and this is a really good example of where that collective action is probably needed a lot more, because as you mentioned before, the reasons behind why people drink, it might be stress, it might be mental health, it might be debt, it might be lots of other things, but there are other compounding issues that exist in those wider determinants really, which is what's driving that. And actually, we tend to focus on the alcoholism and the kind of medical intervention as opposed to the societal side of it as well. So I think this is a great opportunity to work at a cross-sector level.
Definitely.
Yeah.
Hi, thank you. Okay, so from my perspective in my job in ANIC, it's just endemic to many of the different problems I see. So I can see an elderly lady at home who can't speak straight to me in the morning because of alcohol-related issues. I can see a mum who binge drinks when her parent takes the children off her once a week. I see the results of the RTAs. It's just endemic. It's, I can't have a surgery without 2 or 3 people out of 20 who probably have some form of alcohol issue. So I could talk at length about that. I think in this room, one of the strengths is that looking at this, the issue is truly multi-agency, that we can only do something about this. So I'd be really fascinated to hear from a police perspective. From a driving thing, I think the risks of getting breathalyzed just because I'm driving are minimal. And why is that? What policy would need to change to make it feel a much greater risk just to be trying to go about my daily business if I've had a drink? And I'm sure there are many people in Northumberland who do that. And probably the law says that we can't just stop people and breathalyze. But that might be one of the things that would impact, and it would be interesting to have a debate about that. Our combined authority, where is the cultural change from a combined authority perspective? We are Northumberland, but we're part of a big picture. And if we're wanting to change policy in the North East, what role would they have in how we can change this? From fire and rescue's perspective, you must cut people out of horrific accidents. Where is your kind of preventive role in some of this as well? You deal with the consequences. You can't do much about it when that's happened, but we could all have a key form in this. Young mums, you'll see them, Ashley. You'll know, when we know the harms about young people. So the work we're going to do with the Institute of Health Equity on young people and that side of things, it's everywhere. But it would just be for us all to take this away and think, well, which bit of my organisation could I impact? Thank you.
Yes, John.
I'll respond to some of that if you don't mind. I mean, it's definitely an issue for us. It has been for years and years. I think at the minute, we see around about 70% of our crime has got an alcohol link. So it shows how much of a problem that is. We're very much involved in the problem solving side of it. And, I've worked with John and his teams before on various projects on how to tackle that issue. And a little bit going back to what this gentleman says, we find that some of the hardest problem solving is with those people who have alcoholism, the ones that are, it's been like that for a long, long time. Changing that behaviour is really, really difficult. So the prevention work from a young age is really important for that. Coming back on what you said about, well, firstly, we looked at those the graphs that you put up, the data that you put up, and it very much sort of sent towards that southeast corner of Northumberland again, where the population's higher, denser areas of deprivation, etc. However, well aware that in the rural areas we have, same issues, but just not the same amount of numbers, not the concentration of populations, but still some really sort of acute issues that we don't know about until it's too late, because they're living in a remote farm somewhere, or they're quite isolated. And I suppose that comes back to your point around the chance of being stopped and breathalyzed and things like that. It probably is greater in the urban areas where there's more resource and it's a tighter geography. Out in the countryside there is challenges with that because of the geography and the resource that we have out there. But then we do rely on that on the community telling us where they feel there's an issue. Although obviously that's not fail safe. It doesn't, we don't get those reports all the time, but it is unfortunately sometimes a response to an RTA, like you mentioned before, a crash, somebody leaves the road, and then we find that. huge geography, set resources. We need that community information so we can be targeted around what we do in those more rural areas.
Yes.
I told myself I wasn't going to talk today and I was just going to listen, but I need to join in now. Brilliant presentations as always, and I suppose before we move away from the policy side to start to talk more towards treatment, it's brilliant to bring it here. It's also coming into the Strategic Community Safety Partnership as well because of the crime and disorder aspect, and also it's great that we've got Tasman here as well from the licensing team. Sorry Tasman to call you out from a public protection perspective, because it is that drive from national policy to what we can do at a local level. We do have our licence and policy due for renewal next year. So we are going to be playing through this strategy into that. But it is back to Sue's point about what can we do at a local level, that we need the levers at a national level for us to be able to work towards. And I think the learning from tobacco is huge for us in the alcohol world, isn't it? So Neil, picking up on your point around the hardcore aspect of alcohol, we're at that place now with tobacco that we're down to 8.2% of the population smoking, still 22,000 people in Northumberland smoking, but we know who they are in the sense of their demographic profile, because over the 25 years or so we've hacked away at the legislation and the policy and the strategy, as well as that supporting people into alternatives. So that's the road that we need to follow with alcohol, isn't it? And I think that the strategy that we've got is the path for us to follow, but we do need to have that advocacy in relation to changing the national policy, as well as the sustainable funding to support the treatment side as well, which I know we're going to move on to.
I have one question. I agree with you. The price differential needs to be tackled, and also that's a good point from Neil that we need to advertise people against drinking and the harm, the relationship. I think if I remember correctly, the Scottish government tried to do something about pushing the prices up in the off-trade thing. Is there any evidence it helped? I just want...
Yes. So it was 2018 that they introduced minimum unit price in Scotland. It's been accompanied by a number of different things as well. So restrictions around opening hours for off-trade and things like that. But the evidence has been fantastic from Scotland. It's a really comprehensive Public Health Scotland document. And that shows that it had an impact in terms of reducing deaths, reducing hospitalisations linked to alcohol, and other things as well, very much at population level. But I think I mentioned the kind of differential. Scotland used to have the highest rate of deaths.
Yes.
The North East has now overtaken Scotland. So the reduction has been greater, whereas ours unfortunately have been increasing. So I think we've got the most to gain as a region from national action to really complement the local action that Jill spoke
Because
about.
when you put that graph initially, I think it's John who did it, the rest of England, we are far above rest of England actually. It looks like we are pushing the national average much more than, so we are in a way very similar to Scotland in that aspect.
Similar.
We need drastic action, isn't it? Yeah. So it highlights the importance of alcohol strategy and go for it. Okay. Yes. Yes, Andrew, please. Sorry,
Thank you, Chair. No, absolutely fine. Sadly, great presentation, really thought-provoking statistics. Sadly, from a service perspective, we also in children see the impact of alcohol, not just on our young people, but on very young children, babies, and parents in the wider family infrastructure. But actually, I wanted to say something around a different role I have, which is the chair of the local domestic abuse partnership. So for me, our statistics, as you stated, Chair, are rising and actually very likely pushing up the national, the average. We're contributing to that national rise. So I feel like there's a call to action here that's much more about the document, the strategy, the approach. It's how do we make sure at every single level that our partnerships are connected back to what Graham was saying. And a number of us here have roles where we can make sure people are cited on this, and actually it connects into our local strategies as well, so that we are seeing a joined up system-wide approach. So my commitment from here is I will make sure that is joined up with our domestic abuse, that we either consider really carefully adding these slides in detail into our next board for information, or in fact that we invite you to be part of that so that we can see that and consider and take that from our feedback as well. Thank you.
Thank you very much. Thank you. Are there any questions, discussions, suggestions? Oh yes, please, Abby. Yeah.
A completely different topic. You mentioned in your report about how in younger people there'd been a decline, and I wondered if that was how historic that was, because as a parent of later teenagers, I would certainly recognise that people in their 20s drank less. I see it going the other way again. And I wondered around, you know, when we talked about smoking and we talked about some of the vaping and the flavours like bubblegum and stuff like that, which is very clearly targeted at children. We have, you know, I'm a child of the 90s, I remember the Alcopops. That's all coming back as well in terms of the WKDs, the hoochers of the world. Is there at the same time, are we looking at that, not just the marketing of it, but the flavours that are used? Because clearly that's about masking alcohol, and it's actually making it more palatable for kids, isn't it?
It is, and it was probably about 2008 when the statistics started going down slightly. I think we know the alcohol industry is incredibly resourceful, it's incredibly well informed when it comes to researching its audiences, so if it sees any dip in certain kind of potential client groups, such as young people, then it will, you know, kind of model its products. I think women, for example, were an absolute prime target as well for alcohol marketing. So if you think, you know, probably 10, 15 years ago, it was the rise of the pink gins that I mentioned, Prosecco's, and the way that women have been aggressively marketed to the point now where women are starting to close the gap when it comes to alcohol harms with men. I think young people, again, you're right, will be aggressively targeted because their consumption has been reducing. So I think anything that drops, No and Low is an absolute prime example again, that it feels like it kind of fills a space for people who aren't necessarily drinking. You know, John's point about kind of displacement, the fact that people are drinking it on top of alcohol as well. So I think all of this kind of product variation is absolutely crucial when it comes to that increase in harms and the increase in consumption.
Thank you. Thank you. Right. No more questions to Sue, so let's move on to Sarah Hulse on NHS role in alcohol prevention. Over to you, Sarah.
Hello. Hi, thanks very much. And as I mentioned before, my name's Sarah Hulse. I'm the Alcohol Strategic Manager for North East and North Cumbria ICB. And I've been asked to come along and talk about the role the NHS has as a partner in preventing alcohol-related harm. This isn't kind of a comprehensive list of everything that's going on. It's more about giving you a flavour of why the NHS is a really key partner and some of the initiatives that we're taking forward at the moment. So thanks for John and Sue, because they've given a really good kind of context background about why this is needed. And the integrated care system, which was what was in place really before the ICB was established as a statutory organisation. So more than 5 years ago, identified alcohol as a priority for prevention. As we've heard, we've got rising rates of alcohol-related harm. So that was really, you know, one of the key drivers for that. You know, not only it really affects our communities, our, you know, people, but it also is really costly, and I think John mentioned that. But what we know is that collaboration and integration is really key to tackling this. So that's why it's really important as the NHS as being a really key partner in that. And I think the other thing to mention, I'm going to have a slide that really demonstrates this, is that the NHS is one of the places that people access. They often access the NHS when they don't access any other services. And it's often the most vulnerable people and the people with the highest needs that come into the NHS's door. So it's really key that we're a partner working with local authorities, all of the other organisations in reducing alcohol-related harm. And this is all put in the North East North Cumbria Health and Care Partnership Strategy, Better Health and Wellbeing for All, which was published in 2022. And so that identified alcohol as a priority, but also the fact that we need to really work to reduce alcohol-related emissions, and there was a target around reducing those by the end of the decade. So, as I mentioned, I thought I would just show this slide. Now, I appreciate the little kind of icons are all quite small, but this is from a piece of work that we did last year that looked at population of men in North East North Cumbria and looked at patterns of healthcare use. And what we did was compare people who had risky drinking or some kind of alcohol-related harm on their health records and compared their healthcare usage with people who didn't. And through that, we could identify different cohorts of of drinkers and people who are experiencing alcohol-related harm. And this represents, so don't worry, the dates have been changed and things, so it is anonymous. But this represents a journey of someone in the kind of more complex high alcohol-related harm group. So it covers a kind of time of around 6 years and shows every year, so every column in is a year, what contact they had with various different parts of the NHS. So there isn't primary care, there isn't GP practice in here, but everything kind of else is in here. And you can see, so the yellow icons, those are A&E, the blue ones are outpatients, and then there's inpatient stays represented by a bed, and there's call-outs to 999 with the person with the kind of headset on. And unfortunately, right at the end, there's a tombstone because this person dies. But I think what it really, really demonstrates is that every year there has just been so much contact with the NHS for this person. And therefore, there is just a huge opportunity for support and making sure that we're doing the right thing at the right time. So that, I guess, gives a context of why we have an alcohol prevention programme, which is part of the Healthy and Fairer programme and the ICB. It was initiated in 2020, so I've managed the programme since then. And I think the aims of our programme really echo what's in the Northumberland strategy. Obviously, our focus is around the NHS and scaling up our contribution to prevention. But absolutely key to that, everything we do, we work in partnership because we know that, you know, we have people come through the system, don't they? They don't just come to one service. They have, you know, so much contact across the board. And I think we can only really tackle this issue if we work together. So what I thought I would do now is just talk through some of the initiatives that we've been involved in. These are all at ICB level, so across the North East North Cumbria, but Northumberland has been a key partner in all of these. And it just gives you a flavour of the work that we're involved in and the kind of potential of working with the NHS. So the first one I wanted to mention was the Stigma Kills campaign. So this is a campaign that was developed actually by the NHS Addictions Provider Alliance. And it was really focused on all types of addiction and the stigma that we know it is often associated with those addictions. And we know that stigma is a real barrier to people getting the help that they need. And what that does, if people aren't accessing the care that they need at the right time, because they're concerned about stigma or because they feel that a kind of door has been shut in their face, then they're not getting the care they need. And what that does is increase alcohol-related health inequalities. So it means that people who do drink too much are more likely to have worse health outcomes. So we know through feedback from various places that actually addiction-related stigma and alcohol addiction-related stigma is an issue in the NHS with our own healthcare providers. And so what we wanted to do was raise awareness of alcohol-related stigma with our healthcare professionals and really put them to about why this is a really important thing, that we need to actually reduce the barriers to access and experience. And as a healthcare professional, they're really key to do this. So what we did is work with the NHS Addiction Provider Alliance and develop some of our own resources for the North East North Cumbria, focusing on alcohol, focusing on healthcare professionals. We developed this video, which the link is to there. And this really, it has people with lived experience talking about how they felt when they accessed healthcare and they felt they were stigmatised because of that. We had specialist nurses talking on there as well about how we can overcome that. And that really kind of links to these 3 straplines: stop, start, ask. So stop using words that hurt and isolate people, start thinking about why someone might be ill, and ask if they need any help or support. And this campaign that we did was really focusing about hospital care, and we're planning to actually develop a further campaign more based in primary healthcare, so kind of GP practice settings. So the next initiative I just want to tell you about is alcohol care teams. So for those of you who don't know, alcohol care teams are specialist nursing teams based in acute hospitals, and they support and look after people who are dependent on alcohol or potentially dependent on alcohol or experience some level of harm. North East Northumbria ICB has actually funded alcohol care teams across every single acute hospital that we have, but actually in Northumbria there is the alcohol care team has been there for several years already, and so what we've been able to do is enhance that specialist team within Northumbria Healthcare Trust. And one of the things we've done in all trusts, and including Northumbria, is put in recovery navigators into the alcohol care teams. So this role is really about thinking when someone is discharged from hospital, when they go out of the hospital, how can we prevent them from kind of falling through that gap? We want them to be able to pick up and get the care and support they need when they're in the community. So that's what the recovery navigators do. And we have shown that there is big benefits to the system with alcohol care teams. There's a lot of national evidence anyway about benefits to the alcohol care teams, but we've been able to show that we've got better integration between services, increase in referrals to community treatment, and absolutely crucially, not just increase in referrals, but when someone is referred, they're more likely to actually maintain it within that treatment. And obviously, it's great that there's also benefits to the NHS. So we've been able to show really significant reduction in hospital admissions and A&E attendances the year after someone's had care from the alcohol care team. So my final bit of work that I wanted to share with you today is around the NHS and their role in supporting the system-wide workforce learn around alcohol-related harm. And the way that we've done this, and again, this is very much from feedback from our partners, both within the NHS and out, that there was a need for more training and awareness raising around alcohol-related harm. So we've developed something called the North East Northumbria Programme for Alcohol Studies. Some of you may be familiar with the Boost platform already, which is the ICB learning and improvement kind of online platform. It's called Boost, and on there is the Learning Academy, and that's where our Programme for Alcohol Studies sits. So it's basically a training programme that is available to everyone. So it's not just for NHS staff, anyone, any kind of practitioner in any agency, who is interested in reducing alcohol-related harm can access that. And we've got many modules that cover alcohol awareness, alcohol screening, brief intervention, management of harm and dependence, and those are just some of the ones that I've put in there just to give you a flavour of what's on that platform. So finally, thank you very much for listening. I'm happy to take any questions, and thanks for seeing me, letting me come here and talk about the role that the NHS plays. I would say obviously the NHS is a huge organisation and there's a lot going on and a lot going on locally which I haven't been able to cover, but hopefully I've given you a flavour of some of the things that the ICB leads on.
So thank you very much, Sarah. Thank you. Are there questions for Sarah? Jeff, please.
Not so much a question, just a comment. Thank you, Sarah. On a monthly basis, all national DPHs have a call with the Chief Medical Officer, Chris Whitty, and we are seeing, unfortunately, some ICBs moving away from their alcohol prevention work and the alcohol teams disappearing. So I really do hope we can continue the brilliant work that is happening in the North East and in Northumberland specifically.
Yeah, thanks. And I think the support from DPHs in pushing the agenda and the need for this work carrying on within the NHS is really, really valued.
So these alcohol studies you mentioned at the end, so the results of these studies are pushed to practitioners, and it's within a closed system, is it, or is it published elsewhere?
What we do is we put, for example, there's a new module that's just happening. It's an online webinar that's happening around joint risk factors. So it's actually looking at how smoking, alcohol and healthy weight are very much connected, and we have a very similar kind of population who those three behavioural factors affect. So that module has just been put on that platform, and then we promote it throughout our networks. So it really is, based on the strength of the partnerships that were involved in those networks, and we've had thousands of people, and we keep an eye on who's accessing that platform, and we know that we've got a very good geographical spread, but also really good spread of where those people, in terms of what organisations they're placed in. So we know that we are reaching, more than just our NHS colleagues.
Any? Yes, please, Neil.
It was just an ask, actually. Could we get the slide pack afterwards? The slide that you put up that was the visual representation of the interactions with the different parts of secondary care. So I know it didn't have interactions with primary care in there. I'd love that to use with my social work teams, actually. I haven't seen a better visual representation for one aspect of the system of just how busy the interaction would be. So it was just a please, if I could get that afterwards, that'd be great. Thank you.
You want to comment?
I'm smiling because you probably, if you put primary care contacts on there, you'd probably just blow the whole thing.
Exactly. And I think just to add that is that the primary care contacts, they wouldn't necessarily be coded around alcohol. So, as colleagues already said, a large proportion of the people coming in through the door, it is actually because of alcohol, but we don't necessarily have a way of documenting that effectively.
Thank you. And so let's move to the fourth presentation. Sandra Green on alcohol addiction and recovery.
Thanks very much. This is the second time I've presented for John, and the second time I've been last, but I can see why I'm last today. It falls into place. I'm with Amy, my colleague. We're both non-medical prescribers within Northumberland Recovery Partnership. So Northumberland Recovery Partnership, we cover the whole of Northumberland for anyone 18 and over who is experiencing problems with drugs and alcohol. We have a very strong belief that recovery from addiction and substance misuse is possible, and we aim to make recovery a reality in Northumberland. We're also there for the family and friends and the community, for people that are supporting people with drug and alcohol problems. We are a partnership. Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust are the lead provider, and we're in partnership with Way Through for a very important reason. Way Through have a large percentage of their workforce have lived experience, and we find that is essential within this field. So we benefit from a shared vision, accountability. We very much try and align our activities with the health priorities. Obviously, partnership working's got its benefits. We try to reduce the inequalities, focusing on shared goals and effectively using the resources that we have. The lived experience, I can't stress that enough. We need that visible example that recovery is possible, and these people contribute their invaluable insight to our service users accessing our services and improving the design of the services. We've already covered a lot of what is in the Northumberland alcohol strategy and what has already been presented about the problems of alcohol use. We are seeing a lot of new presentations of people who are older, and that's got its own problems linking into general practice. We're seeing, they've not only got the problems of older age, but they've got the problems of alcohol use thrown into there as well. And whilst many people do safely consume alcohol without harming themselves, we're in that business of major health concern and the fact that this is preventable. Just a map of the body. What is affected, it's probably easier to say what isn't affected. Alcohol-related brain damage, but also what we see is traumatic brain injury from people falling. The amount of our clients that have had multiple CT heads from the amount of falls they sustain. Just every organ of the body affected. It was interesting to hear about the targeting of women for the alcohol advertising, because although we're seeing men having double the rate of alcohol-specific deaths, alcohol consumption affects women more at drinking less because of their body fat composition. So it really is a risk factor that we need to get over to our female populations. And as we know, alcohol is a group 1 carcinogen, same category as asbestos and tobacco. We've talked about the social problems, the links to crime, antisocial behaviour, increase in domestic violence. The clients that we see on a day-to-day basis, it's very sad seeing them coming in and that they've lost relationship, homes, their jobs, they've lost their driving licence, so they can't do their job. And basically it's a loss of identity, and they are lost themselves, they don't know where to go. Contributing to debt, poverty, safeguarding issues. Coming on to what we can do to reduce the alcohol-related harm, two-pronged approach, prevention, education, and effective evidence-based strategies. I can't kind of stress the education enough, and it comes out of health assessments that are not new to our service, but it's becoming more prevalent and more important that we get the information over to our patients that alcohol is harming them and they can do something about it. The benefits of that health assessment, getting their bloods done, looking at their blood pressure, getting them referred for a FibroScan, which we'll come into later, so that they know what's happening with their bodies and hopefully they can make an informed decision about what they do next. We offer recovery groups, a 12-week abstinence programme. We can do work one-to-one. We can get them signed up to online work if that's something that they're struggling with anxiety, so they don't feel they can do that group setting. So we will look at the individual and try and deliver what's best for them. We offer alcohol detox. We've got a community pathway and an inpatient, and we assess people, and it's never assumed right at the start which pathway they're going to follow. We're looking at this as a multidisciplinary team, what they want as well, and taking into account their carers and their friends' support. We are offering more medical support from an anti-craving medication point of view. We do have challenges, as everybody does. We've talked about the sheer size of Northumberland, getting a patient from Rothbury over to Ashington, one of our bases, is a real struggle. So we'll go out, we'll use GP practices, and basically any other kind of offer of accommodation that we can. And we see people in their own homes. And from, just going back, I've just missed, the group settings, the one-to-one support, a lot of this is delivered by our staff with the lived experience, and that's what the patients can relate to. it's a problem providing a home detox option for people who have isolated themselves from the very people that we need to support them at that time. So friends and families who might support a home detox are no longer around. So we have the opportunity that we can put them into a hospital detox. We've mentioned, Sarah's mentioned about stigma and how that it's a barrier for getting people into our service. We've been seen as an opioid service for a long time, and it's about getting that education out there that we are able to deliver a full alcohol programme. And also people's stigma, I'm not going to that service because all they see is people using drugs. So increasing the awareness of what we offer is a real challenge, and I'm hoping that comes back because I have not committed these to memory. Anyway, it's up there. So during COVID, Northumberland Assertive Outreach, NAO, was established, and this was particularly those clients who are drinking, very entrenched in alcohol, and it's about providing that weekly care and support to try and get them to a point where they can access structured treatment. We have a designated criminal justice liaison team, and we're working very closely, thank you, working very closely with probation in order to support people. We are offering appointments straight out of prison because this is when people are most vulnerable. We are we've had a number of new posts. Mine was one of them. I've been in post around a year. We had the inpatient detox pathway. We now have the dedicated home detox pathway. We are looking to recruit an older persons worker in acknowledgement of that increase in age. We've talked about the outreach approach, use of the GP surgeries, getting the links with the GPs. We have a dedicated dietitian service within CNTW, and we regularly get the dietitians on board because people are drinking, they're not eating, they're not getting the nutrition that they need. That's having a detrimental effect right through their body. We have links with now, we have a monthly interface meeting with the Northumberland Head Injury Service, again going back to those falls and the brain injury that can occur and the benefits from linking in with that service that we can use to enhance somebody's life, educate them on what they can do to improve their particular situation. The alcohol team that Sarah mentioned within the hospital, we have a weekly meeting with them, and they can flag to us somebody who may have gone into hospital who they want to refer into us, and we can assess them while they're in hospital. We can go out and visit them. We can make plans for their discharge. We can link in about getting them the anti-craving medication started in hospital so it's established, and then pick that up on them being released, being discharged. I do apologise. I worked in a prison, so release, discharge. It comes interchangeable. We have peer support workers, again, that lived experience. It's visible recovery, proof that recovery is possible. One thing that's not on the slides is the IPS service. It's been within mental health CNTW for a number of years, but we now have 3 workers within our service, and it's about not just recovery from alcohol, but it's taking that next step, getting into work. They may not have been in a job before, or they may have been in a job and need assistance to get back in working. So we're doing that as well. And that's going down very well, actually. So we're seeing more people going through detox. We have changed our initial referral and assessment process. So somebody now rings up the helpline, they can get an assessment there and then over the phone, and then they can be brought into service. If they've stopped drinking, the workers doing the assessment can access a prescribing appointment, and then the next time the person's seen in service, they're actually seeing a prescriber to get them on that, to that anti-craving medication. And put B12 in there because a lot of the people that we're assessing were doing their bloods and they've got a very low level of B12 because they're not eating. This leads to them feeling tired all the time, their mood's low, their motivation's low, they really don't know what's wrong with them. And if anybody's got a B12 deficiency, they'll relate to those symptoms. So it's I won't say an easy fix, but it's something that we can focus on and help with and refer back to the GPs. We have a good relationship with NCC and their smoking cessation programme. We deliver their smoking cessation programme. Often goes hand in hand, as has been mentioned. So they're sat with a drink, they're sat with a cigarette. One is the trigger for the other. So we can look to addressing both at the same time, although some people are really scared about that and then pleasantly surprised that they've achieved it. We are doing more referrals for fibrous scans. Again, educating the patient, this is what your liver health is. It can get better if we cut out the drinking. So they've got an incentive. So the patient education for us is really massive. And then we come to the end. Alcohol generally accepted as part of life. We know it causes huge problems. Tackling the harm that alcohol can cause is a priority for NRP. Thank you.
Thank you very much, Sandra. It was, I think you're doing lots of things in several ways. I think it's really uplifting to hear all those things you've been doing, especially the detoxing beds and everything. So it's very impressive.
Yeah, but having that, we do the pre-work before detox, and then we're encouraging people to sign up to that very important psychosocial intervention.
Right, thank you. Are there any questions for Sandra? Yes, please.
Sorry, Chair, more just a point to make in that the police, my teams already have a really good relationship with NRP, and NRP are involved in a lot of the problem-solving activity that we do around reducing crime and social behaviour, because there is, like we've already discussed, more than often there's an alcohol link. So I have some really good sort of relationships and some really good joint working.
Mm. So do you automatically advise that person to contact NRP, or how this?
So there's referrals through the Frontline app. We can refer through there. Yeah. But as well as that, we have different initiatives that target probably the highest harm causes or the person that's a repeat victim. And there's always a representative from NRP comes along to those meetings where we'll discuss that individual and the referrals made there. There's different discussions around the support that we can provide that individual, depending on what their need is.
Yeah, yeah.
So it happens in a number of different ways.
Yeah. Thank you. Yes, Jill, please.
Thank you. It was a brilliant presentation. I always think it brings it to life, and having been to NRP, that lived experience is absolutely critical, isn't it? And I know, I'm sure you won't mind me saying, if people haven't visited NRP, it's really worth going along and understanding addiction from that perspective of a positive can-do approach that you have, that it instills hope in everyone, and it also normalises and starts to reduce that stigma. So it's fantastic that the work you do, and also we're delighted, John, aren't we, that the public health grant is going to be a 3-year commitment going forward, so we're able to consolidate and look at sustainability of NRP as well, which is really important for us. And also, John, massive thanks for all of the coordination that you do, because it's been a fantastic session this morning, so thank you.
Okay. So I have one question. Maybe I'm exposing my ignorance here, hypothetical questions. Yeah, I work in the university, lots of, deal with lots of young people. I'm imagining a hypothetical scenario. One of my tutee comes to me and then says, I have some alcohol problem, right? How will I usually I was told to refer to welfare officer or within this one. So how could I advise that person without going to another chunk? Is there a central point where please contact this person or please ring this number? Is there anything there? Because what I'm asking coming back is that for that person to come to me and then ask for help is big. It would be better, like if there is an emergency, we ring 999. Is there a kind of a number for, maybe it is there, I'm not aware of it, so that's why I'm asking.
Professionals email, yes. So, you know, that's a good point. We could make sure that that's out there.
Yeah.
And you email, you can refer that person in.
Right, okay. So what I'm asking is there a general email or something like that where the person can straight away go to if they feel like if there's a break-in in my home, I ring 999. Is that, you know, there's a common email or telephone number. Is there a common email address or something like the generic email address? I can just Google it and then go.
Yes.
Yes. Okay, thank you.
They'll get straight through to the helpline, and that's where we triage and assess as soon as they ring through. We don't make an appointment for an assessment. We do it there and then.
Okay, right.
That's one of the changes we made.
Okay, that's very good. Yeah, good to know.
It is, sorry, Chair, just coming, it is also on the council website. If you
that's
just,
it, right,
search
okay.
drugs and alcohol on our website, the details are on there.
Right, okay, yeah. Sorry for my ignorance. That's why I said, you know, I may come across as a person who did not know. Yes, Abhi, yeah.
I know that the NLP is on frontline, so people can see about the service and they can request a callback. Is there any way that, or is there any plans to be able to make a direct referral where somebody isn't necessarily an emergency case, but maybe that, you know, whilst they're getting support, say from a CAB perspective, they might be getting support for debt or some of those other issues, and being able to make that referral directly rather than just signposting or to get a callback?
Yes, there is the professionals email line that you can use.
Right.
So we need to make sure that that's on the contact details.
Yeah, because it is as a kind of an employer, it is my duty to help the other person, isn't it? So that's the reason I'm asking.
Thinking about how the best way to get that support, as we've talked about, it is about cross-agency, multi-agency working, isn't it? It's just how do we make sure that's as easy as possible.
Yeah.
Please do.
I've already had some conversations with John about that interaction between NRP and primary care as well, and I think there's a lot that we could do that would smooth the ways around understanding what works in terms of referrals. So I think we've already said that we'll sort out some meetings, but I think what Abby's just said illustrates the point that there's a bit of uncertainty about what the truly most effective way to get people in touch with the service is.
Yes.
There's probably an anxiety that will flood you. You know, and yet we also identified that coding in general practice is really poor, so there's this complete lack of knowledge about the unmet need in some respects as well. You know, so the more people that get referred into your service, the more we know that actually, you know, not all of them necessarily will engage with your service, but at least we start to see where the need is and how do we do something about that as well.
I'm sorry. Yeah. John, that's final steps to you. If there are no more questions, then we can move on to John. Thank you.
My screen's gone blank.
Oops.
Some money in the meter. Right, yeah, I'll go with that.
Yeah.
Thank you. Okay, so we'll just take just a little bit more of your time. Just so you've heard a lot of information today, a huge amount of info, really. And that's the, you know, the kind of thing that we were using as our, I suppose, foundations really of kind of developing this strategy. And it's nice to hear actually back from people who've had a look at it and find that it's an easy read. That was we wanted that, and that it contains a lot of useful kind of information. So just to offer some additional, I suppose, assurance around this, that this this wasn't kind of written in a cupboard somewhere. It was written very much based on us going out and speaking to people. We spoke with a lot of people, and you can see I've been quite busy with the little emojis and icons, keeping myself busy yesterday afternoon doing this. So it's spoke to a lot of people. They're not all represented on there. I ran out of icons in the end, to be honest, to represent. But you get the general idea. Sarah mentioned the alcohol care team. I'm just going to give them a little bit of a shout out, actually, because they are on there, the top right hand corner there. And we went out to speak to them. It's a fantastic service. It's difficult to do them full justice, actually, but the sort of feedback and insight that they provided based on their expertise was phenomenal, really. Just an incredible amount of information. They spoke a lot about alcohol-related brain injury amongst a lot of the people that they see, often undiagnosed, often as a result of repeated falls, repeated blows to the head, where people are presenting in perhaps a confused state. It could be actually judged as perhaps they're intoxicated, but it's actually a brain injury they've received. So it kind of brought home really the huge amount of damage that we're potentially dealing with here. We did speak to people with lived experience, which was of course done very sensitively, because in some cases this was people who the lived experience was very recent, or in 1 or 2 cases actually ongoing. So as I say, that had to be done in an incredibly sensitive way. So where did that take us? Okay, so what we got is in terms of some of the feedback. What I'll say is that what pleased me is that a lot of the stuff we got back at us, because I'm talking a lot about that we spoke to people. Actually, what we did is we did a lot of listening, and what we got back to us told us that people are actually quite informed. They are quite aware of what's going on. They don't necessarily have an enormous amount of knowledge of statistics and figures or services, but they're quite aware of what the harms are associated with alcohol. And we got some really good stuff back. There was very much a sense that communities want to have a say in what we do, and that was always our intention, but it was good to have that reflected back at us. We did, as you would expect, people did associate alcohol with crime and antisocial disorder. As I said earlier, there was a very, very strong perception around that. We talked a lot about assets. You've heard today about a lot of good work that's already taken place, and we want to really strongly acknowledge that. We're not starting from year zero here. There's already some incredible work taking place within communities that's having a major impact. Part of the idea of the strategy really is to kind of stitch some of that together, not to reinvent the wheel, certainly not. This has been mentioned. John mentioned this before about some of our more rural communities. Talked a lot about isolation and loneliness being a trigger for alcohol use, and how difficult it can sometimes be to get into those communities, although we are doing some work around that. The bottom left one I found quite interesting, because people did talk quite openly about the normalisation of alcohol within society, and how in some cases people who had experienced harms actually felt that the environment that they lived in had enabled their alcohol use in some cases, and it had been incredibly difficult to stop because of where they lived and their kind of social networks that were available to them. And the bottom right one there, Sarah mentioned this, is the stigma. People did feel in some cases that there was a stigma, interestingly, around asking for help. Not so much a stigma about identifying a problem with alcohol in the first place, but certainly when the point came to ask for help, people felt that that was a very difficult thing to do because of this perceived stigma. We've heard about this. I'll not go into too much detail about that. That's just the priorities we came up with. I hope they make sense. They are there in the strategy document. That's the type of thing we want to do. There's a lot of kind of KPIs and targets that will feel the benefit from the work we do around this. Just an example, we heard Sandra talking about her service, NRP. About 1.5 years ago, we started quite a focused piece of work with NRP around improving the outcome for alcohol users. And with their support, with their expertise, we were able to very, very quickly see a turnaround in that, in terms of increasing the numbers of alcohol users who are accessing treatment and also improving the outcomes for them. But we want the impact to be felt beyond KPIs and beyond the kind of the data. We want it to be a little bit more meaningful than that. And some of the things on here is the type of things that we want to kind of make an impact on. Certainly around, we want people to recognise that help is available for them, and that the right information is out there, and also to recognise that we can make our community safer by addressing some of these issues. I think the last one from me, so just in terms of governance and accountability, who do we answer to? Well, we want to answer to everyone, really. We want to be accountable, of course. Obviously, there's a list there of people who officially we would certainly be accountable to. So obviously our cabinet member, Councillor Chicken. We've got our Drug and Alcohol Network, the Safer Northumberland Partnership, who we work really, really closely with. This meeting here, we'd like to come back in the future, perhaps in a year's time, and give you an update of where we're at and what we feel we've achieved. An enormous cast of partners and stakeholders, a phenomenal amount of people who were networked with and engaged with. What I would say is that as part of the consultation we did, and this, I've mentioned this action in the bullet point below, is although we did an initial round of consultation and engagement that took about 6 months, that hasn't ended and it won't end. We're still having conversations with people, people are still contacting us and saying, I want to talk to you about this because something's happened at work, or there's something I've identified within my community, and can we have a chat about that? We'll just continue that. That'll stay open-ended, because, as I say, we want it to be based within ideas and actions that matter to our community, and we'll only do that by continuing to talk to people and continue to listen. And that's it. We've given you a lot of information today, an enormous amount. I hope it's been useful, and judging by some of the questions, a lot of it's landed really well. As I say, that what we're all of us are available to continue to take questions and continue to answer anything. What I'll say is that me personally, as the drug and alcohol lead for the council, if there's any networks that you're involved in, or any forums, any groups where you feel they would benefit from someone coming along and giving a bit of an update around the strategy around alcohol and having a bit of a conversation, don't hesitate to contact me. I'm always available to come out, always available to meet people.
Thank you very much, John. It was a good presentation, and the final plea was also very impressive. Yes, we will definitely, make use of that one. Are there any final questions to John? In that case, we can wind up. Thank you very much. So we all agree the recommendations proposed. Yeah, thank you very much. So thank you, all of you, for your excellent presentations and answering the questions. Item number 6, we are supposed to note the forward plan, and please do note, and if you have any suggestions, please come to me or Andrea or Jill O'Neill. There is no urgent business, therefore the date of next meeting will be on the 13th of November, Thursday at 10 a.m., the usual time. I think there is a meeting on January 15th scheduled, the new year, the first meeting of the new year. This is likely to be postponed, therefore not cancelled, postponed, and we will announce the new date in the November meeting. Okay, just an advanced warning. Thank you very much all thank you very much for all of you coming here, taking part, making all the suggestions. Thank you again, once again, for your presentation. Thank you.